I guess we do the questions at the end. Oh, you're moderating, right? How many more of these are you hosting? Do you have a few more of these workshops?
Yeah, we'll be having more probably every 1 to 2 months.
Oh, every couple of months you're gonna do.
Yeah.
All right. Should I start?
Yeah.
Okay, right, then I'll start. Okay, hi everyone. Welcome to the first of the MR-FFAI workshop in 2022. Unfortunately, we still have to run online. I mean, because of the pandemic is still going on, but we are more than happy to move on site once the scenario is getting better. But I feel very great and honored to welcome our speaker today, Meng Law. So I will briefly read out his bio for you. So Meng is currently chair and a professor of radiology at Alfred Health, director of iBRAIN, and professor of Neuroscience, electrical and computing systems engineering, Monash University. So prior to this, he was the director of the Neuroradiology and Neurology Fellowship Program Director of the Neuroimaging Core NI USD Alzheimer Disease Research Center, and Medical Director of the Stevens Institute of Neuroimaging and Informatics at USC. So he was also professor of radiology, neurology, neurological surgery, USC Tech School of Medicine, as well as professor of biomedical engineering, USC Viterbi School of Engineering. Wow, very, very impressive background. So Meng, then I will leave the stage to you then.
Thank you, Zongyuan, for that introduction, and thanks, Jackie, for organizing all this. And wanted to be able to share my, I guess, our experience and some of my philosophy on AI and healthcare and medical imaging in this workshop. I had a look at some of the prior workshops from last year, and there are certainly some very interesting discussions and topics that are being discovered. Good to know that some of the earlier talks discussed some of the more basic approaches and concepts for AI. So I won't talk about that, but what I do want to talk about today is outlined here. And so we've been clinically using AI in medical imaging and radiology for the past 2 years now in a public hospital setting. So I'll talk about some of the challenges and some of the real-world applications of how we're using AI to detect lung nodules, pulmonary embolism, intracranial hemorrhages, and so on. These are products that are can be purchased by various vendors, and how this can be used to improve patient care, reduce turnaround times, reduce costs, and so on for patient care. Another important topic towards the end, which I'd like to speak about, is what patients might think about this, and should we tell our patients that we're using AI in their medical care? I mean, many of you probably have Teslas. Some of my friends here and also in America have Teslas. It's kind of like, you know, when you turn on the driverless Tesla self-drive program option on the Tesla, you know, how do we know how that works? Do we actually know what the algorithm and how that's been developed? And so it comes back to the idea of explainable AI. I think Tesla should be able to explain to you how that works. Otherwise, you know, there's concern that if you put it on and you crash and cause an accident and maybe even die because you don't understand how it works. And then a question that I'm going to ask everyone who's kind of called in today, and thank you all for calling in. And this was asked to me actually a few weeks ago when I was sitting at work one evening when I was on call, and two of our young trainees and registrars, Chris and Gerald Sia, were in the reporting room, and we were, you know, obviously looking at some scans. And Chris was wanting to invest in AI companies and in AI and healthcare companies. And so he asked me and Gerald, who some of you may know is one of our trainees, who's also works for an AI company called Hanley's, would you invest in a medical imaging or AI startup? So have a think about that, because I'll come and see if I can answer that question. The answer for me is probably not. and I'll try and explain to you why I feel that way. This is part of the reason. There are probably hundreds and hundreds of companies that are dealing with AI in healthcare and medical imaging. And you'll note that there's obviously a lot of very small companies, some medium-sized companies, and then some massive companies that have installed base in terms of medical imaging, like the Philips and GE and Siemens and so on. And then there are a whole bunch of smaller companies that have, some of them quite remarkable tools. So we'll talk about some of these different tools, and you've probably already seen some other, in fact, some companies like IBM Watson, they think may have considerable market share and have tools that might be useful. And I believe that Zhongyuan may have worked with IBM and Watson. Some of these companies, massive companies, have already shown that because they don't have install base in a lot of customers, developing products and then actually marketing and selling them leads to failure. And I'll talk about why that might happen to a lot of these companies. So, would you invest in a medical imaging or healthcare startup? And keeping in mind that some companies, massive companies like Watson Health and IBM, could have potentially failed because of issues with not having significant market share. Let me just go back the previous slide. And it comes down to the fact that if you are a startup and you're trying to sell licenses for your product and for the model and algorithm that you're developing, if you don't have market share already, so the majority of medical imaging companies, like the big companies like Siemens, Canon, GE, Philips, and so on, they're producing scanners and they're producing equipment that already have considerable market share out there in the community. And it's easy for them to really add on, whether it's a plug-in to their current products that they have, or they also have quite large AI and data science R&D divisions that are themselves developing quite sophisticated AI products. And then there's a whole bunch of companies that deal with PACS systems that for advanced visualization of medical imaging, vendor-neutral archive, and then developing now into what we call health imaging exchange tools, where we're actually exchanging not just medical imaging, but exchanging any electronic medical data. So we're looking at things like even the EMR, and then, for example, if you're picked up by an ambulance, the ambulance that picks you up has electronic data in it. Currently, we don't really have a way to absorb that data into our EMR. So these health imaging exchanges not only allows us to absorb all this imaging data and non-imaging data and EMR data that can be used for patient care and AI purposes, but we need a way to also be able to exchange them between healthcare organizations. So if you're a small startup and you're thinking, oh yeah, I'm developing a model and a chest X-ray model or some healthcare model, how will you compete with this? You'll need to develop a model that you can exit and sell your company to one of these larger companies, or you have to figure out some way of selling your product so you can get sufficient market share and increase your valuation so that you can either exit or be independent as your own company. And that's one of the challenges that I think that many of these startups will have, and it's very difficult. So this is presented at our RANSCA annual scientific meeting last October. And you can see that Dr. Parazel, who's a radiologist who chairs the RANSCA research committee, in the last 2 or 3 years has been quite an exponential increase in publications of AI in radiology. Question then is, because there's so much not only research, but clinical application in healthcare and medical imaging, do our patients know about this? So in other words, if you buy a Tesla, you know that there's AI in a Tesla car and there's driverless technology and so on. Most of our patients, and I'll share the results in the second half, of how many of our patients actually don't know that we're already using AI in numerous different settings in the hospital and in medical imaging. So we'll talk about this, and should we tell our patients that we're using it? I think the obvious answer is that we must tell our patients that we're using AI, rather than just caring for them and telling them that all of their care is non AI augmented or supported. This comes to this this concept of explainable AI. I mean, I have no idea how the AI model for Tesla was developed or how it works. I mean, they tell in superficial reading, it's a bunch of cameras that figures out where there's a car in front or behind you, and then uses GPS to figure out where you're going, and then drives the driverless technology. But in the end, I don't know how this was developed, nor will they probably share it with you. But it's led to obviously some accidents. And the same thing with, if you look at all these accidents that occurred, some people have died. There've been a few fires and collisions and so on. And if you then extrapolate this to medical imaging, we know that, and I'll share the results of some of the technology that we've used at our hospital. They've made mistakes, and they've missed hemorrhages, they missed cancers and nodules and so on. How does this impact patient care, and how does this impact potentially patients actually dying or suffering from a mistake that AI has made? So we published a summary of some of the applications in AI in medical imaging. I guess there are three main broad groups, but I think we can categorize this into six types of AI that can be used in medical imaging. One is clinical decision support. We'll talk more about that, how we can use AI to select the appropriate exam, linking patients with CDS to decide whether an exam, if for example, a doctor decides that you need a chest x-ray, we can figure out using natural language processing and CDS whether the patient has chest pain or whether it has lung cancer that requires a chest CT or a chest x-ray. If that's not in the electronic medical data, then the AI will say, do you think this patient really needs a chest x-ray? So CDS, I think, is going to be a very important application. Image acquisition, we can use it for deep learning reconstruction. And we have a few projects that do that. We can scan a patient using lower dose of X-ray and radiation, and then use deep learning reconstruction to improve the image quality. Image processing, it's been used for quite a long time now, whether we can use a model to count and segment a number of lesions that are in the scan. Augmented detection, we can develop a model that AI uses to flag abnormalities, and we can identify abnormalities. We can also use AI in medical imaging for classifying diseases, whether it's radiomics based or whether it's to identify whether a patient has a cancer and whether the cancer is malignant cancer or a less malignant cancer. And Zhongyuan and others, obviously are doing this with melanoma and skin cancers. And then finally, how we can use AI for reporting. So even something as simple as generating a report where we provide a report of the abnormalities that's on a scan to highlighting abnormalities or scans for follow-ups. And this is very controversial because as radiologists, we really don't want AI to be able to do this properly, because then potentially this can jeopardize our job. In terms of CDS, we did write a paper with Graham Jackson and Meng Law Peterson on some of the potential applications in neurology and neuroimaging. So you can read about this in this paper. We had this lightnings talk that our Data Futures Institute put together, and this kind of summarizes some of the examples that I was talking about. So in this project that's led by Winston Chung at Monash Health, we are developing an AI to classify multiple sclerosis lesions, so we can look at the follow-up of these MS patients to detect if there are new lesions. Zhongyuan and Majid, and he can talk about this perhaps a little bit later on, has been developing a model for diagnosis of liver cancer. And Zhongyuan, I'm sure, has talked about his work with Tori Mara about detecting melanoma in skin cancer. Ben Sinclair is developing some deep learning methods for detecting focal cortical dysplasia and epilepsy. With Gary Egan and Zhao Lin and Kamlesh, we're using deep learning for reconstruction of MRI data. We can use this, and we'll talk about this a little bit later on. We can use this for either improving image quality, or we can acquire MRI data with using a very low field MRI scan, and then using deep learning recon to improve the image quality by increasing the signal to noise and moving motion. And then a topic that I guess I'm particularly interested in is what patients think of AI and getting patient consent so we can use AI. So why do we need AI? Well, in radiology, you'll see that we're not only doing more and more imaging, we're certainly have many images to look at. And the fact that we're doing not only more imaging requires us to look at a lot of images to actually detect the abnormality. So the advantage of having trained a model to do this is so that the model can actually look at all these images very carefully and then flag the potential abnormalities for us to look at. So an example is, and I'll show this later on, is for detecting pulmonary embolism. So for example, in COVID patients that have COVID, they tend to have more clots in their lungs. And I think because there are so many images that potentially have clots, having a model that can detect these clots to help the radiologist is very helpful. So, for example, we do 50 to 60,000 scans a year at the Alfred that requires a lot of manpower to look at these images very carefully. So on the whole, there are many images for us to interpret. We're doing, whole body CTs, and you can argue that in the future, every patient that comes into the hospital will just get a scan before they actually even see a doctor. Very often, because there's a delay in the time that the patient is scanned to the time that the image is reported on, this might cause a delay in the diagnosis of a lung cancer, for example. And again, because sometimes the abnormality is very subtle, so rib fractures, we may actually miss rib fractures. And I think this will probably result in a redefinition of how we work as doctors and as radiologists in particular, because rather than just making a report, I think we'll be more focused on caring for the patients moving forward. So you can see in this slide that there's certainly a huge increase over the last 5-10 years in the number of X-ray exams that we perform, particularly with CT and MRI and so on. So when we want to use these tools, obviously if you use an AI tool that any of these companies are producing, it's not free. And I have to ask my hospital CEO for money to pay for this. And so I had to justify how we can pay for this. And yes, it's probably, maybe a quarter or a half or maybe less of the cost of paying a radiologist, but I still need to convince the hospital administration that we need to pay for this. So an example is, and I'll show you that in a minute. So we've missed 6 or 7 lung nodules in the past 2 years when we've used some of these AI tools in practice. In Australia, people thankfully don't tend to sue as much as in the States. So if you're in the States, you would tend to have to pay more medical legally for fees to pay off these patients and settle these cases. In Australia, this is not as strong, and so perhaps the business case for using AI to make sure that we don't miss these cancers is not as strong. There's also the concern, I think, of replacing radiologists with what we call point of care or POC AI in the ED and the ICU. So if the point of care doctor, so the doctor that you see in the emergency department, has access to AI, why would they need to have a radiology report? They can just directly look at the tool on their screens. And so in public hospitals, there's probably more value placed on a human report, and in private radiology, because there's larger volumes of imaging that's done, I think the value of AI is probably higher. So in the public hospital, there's probably more of a discussion between human clinicians and human radiologists, and less, currently anyway, I think, less priority placed on needing AI to do this. So this is a company called Analyse AI that their tool, their chest X-ray tool, can actually detect 124 abnormalities. I can tell you that as a radiologist, I won't even look for 124 abnormalities. So they can look for lung abnormalities, they can look for lines and tubes on a chest X-ray, they can look for heart abnormalities. And for a human to do this requires probably quite a few hours of going through a chest X-ray image to find these abnormalities. But this model can do it in a matter of seconds, right? So the question is, if you and we had a discussion with the company last week, and they said, can I put this point of care AI in the ICU? So here's, for example, an ICU doctor or ED doctor, and if they have access to this and can provide this diagnosis immediately to the ICU, which is excellent, because if you're in the ICU, you want immediate access to a report. Why would they need a radiologist? So the answer I said to them is, we're extremely concerned about this. If the ICU and ED have access to these algorithms, why would they need to read a radiologist report? So number one, not only is there concern from a radiologist point of view that this is available, but Australia is also a little bit conservative. So, for example, the driverless technology that Tesla has is less widely adopted and not even fully available in Australia compared to other countries. And that's because, I guess we're probably a bit safer and a bit more conservative in adoption of AI in Australia. So we do need help in many settings, and I think partly because there are a lot of images, and radiologists are also burnt out, as is the case with many other physicians. These systems and these AI models and products can help rapid detection. I'll show you some of these examples. And not only that, I think we can use CDS and AI to perhaps be a bit more evidence-based. So an example is, using NLP and AI to look through the EMR to figure out that the patient does have the clinical criteria that requires a scan of the neck, for example. If the patient doesn't really have neck pain and doesn't have neurological signs, perhaps this patient may not need to have a neck CT. But a human might order it, but we need NLP to figure out whether it's clinically appropriate. So I think that's going to have tremendous value moving forward with AI. An example is a paper in the Journal of Emergency Medicine of how AI can be useful to triage a patient that if you come into the emergency room at the Alfred, thankfully currently we're not super busy, but you could be waiting hours and hours to see a doctor in the emergency department. So when you arrive, we can quickly triage the clinically ill patients. We can then figure out, take a quick history, put that into the EMR, and the EMR and the NLP can decide whether you really need to have imaging, whether you need to have certain blood tests and so on. They can trigger appropriate level of care for this patient. And then from obviously the results of the radiology and the pathology, figure out whether you're really sick and need to be admitted to the hospital, any adverse events, and then individualize treatment and follow-up. So decide whether this patient needs to be discharged, can be admitted to hospital, or needs other testing. So I think this is really already proving to be quite useful. So how do we implement AI into, particularly imaging AI, into our clinic? There is a paper that the Royal Australian and New Zealand College of Radiology has written, a white paper on some of the concepts and approaches. So the way that it worked for us is that a product is reviewed by the Alfred Clinical Innovations Committee, and then they decide whether this new product or new tool can be used in the hospital or not. We then have an agreement that's is developed between the company and reviewed by a hospital. And then our IDD and digital health group at the hospital will review for any technical risk. And I'll go through that workflow in a second to determine what tech risk might look like. So if we're sending data to the cloud for processing, or we're processing online on premises, it offers different technical risks in terms of exposure of data outside the hospital environment. The hospital ethics committee will then have to review if it's not TGA. If it's TGA approved, then it's obviously something different. But if it's not TGA approved, then the hospital ethics committee will have to review it. And just an example of the tech risk. So when you get a scan currently, the scans are sent to our PACS, our picture archiving service, which is then sent to the workstation for reporting. So the images are also sent to our on-site server, which then either is processed on premises or sent to the cloud. So for example, the AI doc is sent to a cloud that is local in Australia. It does the processing to determine if there's a hemorrhage or a fracture. And then it will appear on a widget on our PACS workstation to figure out whether this patient has a hemorrhage or not. So this is basically the workflow, and the patient is scanned. The scans are analyzed and the abnormality is detected. There's a heat map that highlights a scan for the radiologist to determine if it's a true positive or true negative. So this way we can actually decrease the turnaround time for looking at scans. And you'll see that in our initial evaluation and validation of this product, the tool was not perfect. So there were quite a number of, I guess these are false negatives. So the ground truth, the radiologist found that these were all negative, but the AI doc detected 30 that was positive that were in fact negative on ground truth. So there's a high false positive rate. And this is not such a bad thing. And in fact, most AI tools will be developed to have a higher false positive rate because you don't want to miss any cancers or any hemorrhage and so on. So it's probably geared towards, the model is probably developed and geared towards finding more false positives, so that if there is a false positive, at least a human can validate it and authorize whether the report is really truly positive or negative. And you can see there's also a smaller number of false negatives that can be problematic. Here's an example, and this is one of the early examples of a patient that has a scan. The AI doc heat map supposedly detected a small hemorrhage here that I wasn't able to see. In fact, I was on call this weekend with Gerald, one of our registrars. This patient went to have an MRI scan. In fact, this was what we thought was a false positive. This patient actually has a fungal infection, wasn't really a hemorrhage. So AI doc detected potentially a hemorrhage, but in fact, when we went on to have an MRI scan, it was not a hemorrhage and it was a fungal infection. So when we retrospectively went back and looked at the performance of the AI doc algorithm, it showed us that in fact we missed, as a human radiologist, 6 or 7 intracranial hemorrhages. And here's an example of a very subtle hemorrhage, which we had missed on the report by the human. And the AI doc heat map actually detected an abnormality. Here's another example where the CT scan was reported as normal, and the AI doc heat map, salience heat map, detected a very subtle hemorrhage. Now, when we went back and looked at these patients, fortunately, there was no clinical detriment. So there was no problem with the fact that we missed, and these patients did not develop a bigger hemorrhage and either had clinical complications or even worse, had died from these misses. So the good news is that the human misses did not result in a complication or even worse, a death. So, and these very subtle misses by the humans did not cause any problems. What happens to the TAT, or the turnaround time? Does it improve our generation of the report? And we did a study, and this is a paper that's being reviewed currently, looking at the number of scans that were positive in the emergency department inpatients and outpatients. And you can see that on the whole, after implementation of AI doc, there was probably a decrease in the turnaround time. So in other words, we're more efficient in providing the final report. The inpatient, we perhaps took a little bit longer in generating the inpatient reports, but for the outpatient and ED turnaround times, there was probably a speeding up of the availability of these reports, which is good because we want to demonstrate that if it's a positive scan, we can get the report done quicker. If it's a negative scan, it probably doesn't matter if it's taking a little bit longer to generate the report. Another clinical tool we're using is licensed by a company called Ferrum Health. And this early on in the adoption of this tool runs to detect nodules and lung nodules on a CT scan. And it concurrently runs 2 separate algorithms. One is a machine vision learning algorithm to detect the lung nodule. And then concurrently it runs a second NLP model to determine if the word lung nodule or cancer is in our reports. And then if there's a discrepancy between the machine vision learning model and our report, then it will flag it and it will ask us to review the report for abnormality. And so we ran this, and this is a preliminary study. We had about 3,000 lung CTs. We recommended 7 for report and we had to review, and thankfully most of these were clinically insignificant. And there were some subtle abnormalities. So this is perhaps lung cancer that we missed. And the good news is that, and this is data from Singapore Hospital, shows that it does detect potentially lung cancers that were missed by the human, and this is important. Again, the good news for us, and very similar to Singapore Hospital. So we had also missed probably 6 or 7 cancers and 6 or 7 lung nodules. And the good news is that, again, this didn't lead to any clinical detriment to the patient. Very similar numbers to what we see. So there are numerous lung and chest CT tools out there now, and I've looked at a whole bunch of these different models and products out there. One's developed by a company called Occipit that really amazingly, and this is very on this slide's probably a year or 2 old now, able to really generate a chest X-ray report based on, as I showed you with the Annalise tool, quite a number of 120 or 130 different abnormalities. So quite remarkable that the model can be developed to essentially generate a chest X-ray report, not requiring a human to do this. I'll talk about, this is our CTPA, which is a CT pulmonary angiogram tool under the AI doc module for detecting pulmonary embolism. So a lot of patients who have chest pain, who comes to the ED, can have what we call a PE or a blood clot that can go to the lungs, and this can actually cause death. And you can imagine that there are quite a few abnormalities, quite a few images that we have to look for the abnormality on. So the our radiologists actually think that this is one of the more useful tools that AI doc uses. So the next concept that I want to share with you is, which is superior? Are we developing models now that can in fact be superior to a human radiologist in detecting, say, for example, here, a stroke? And this is work done by the data scientists at Mass General and the Center for Clinical Data Science at Mass General and Harvard Medical School. We had the fortune of meeting this group, and very novel approaches that they developed. So to detect a stroke in the brain, a CT scan is probably less sensitive than an MRI scan. So MRI scan is going to be far more sensitive in detecting a stroke. But every patient that comes to the ED will get a non-contrast head CT. So the concept here is that the abnormality is not visible to the human on a non-contrast CT, but there is very subtle abnormality that we can train a model to detect on a CT scan. And using the MRI scan, which on diffusion imaging can detect strokes to very high sensitivity, we can use the MRI scan to label the human invisible, or so-called human invisible abnormality on the CT scan to detect, develop an AI model to detect abnormality. So the MGH group did this, and when they did this, the model that was developed had 96% sensitivity in detecting a stroke, versus only 66% for human radiologists to detect a stroke on a CT scan. So in other words, a human looking at a CT scan where it looks normal to us has very low sensitivity now in detecting a stroke. Whereas if you train a model based on a gold standard, say an MRI scan or pathology, to detect the abnormality, the sensitivity is going to be much, much higher than human. So in this example, in this paper, it's actually showing that the AI model and the algorithm is far superior to and much better than a human. So other people have started doing this now, and we have some concepts and some ideas of how we want to do this. So for example, if you're trying to find lung nodules, or you're trying to find metastasis to lymph nodes in the pelvis or in the abdomen from the patient that has colon cancer, to the human eye, it looks, the scan looks normal, but we know that in pathology, or perhaps with MRI or some other more sensitive image, the abnormality is there. So you then train the model based on this more sensitive pathology or some other technique to detect human invisible abnormality on a CT scan. And that way we can actually create models that are far superior to humans in doing so. So you can see that in this lung cancer, lung nodule detection, the AUC with the deep learning model is 0.93. reaching the sensitivity of a thoracic radiologist. How much does it cost to run a radiology department? Well, in a medium-sized department, the annual budget is probably going to be $100 million. Our hospital, our department at the Alfred is probably in the vicinity of 60, 70, $80 million to run our budget. The cost of paying radiologists is probably 60 to 80% of that. So you might argue that how much you want to pay a company to use their AI model. Will you pay $50,000 to use their license, $100,000 to use their license? So you could argue that the business case to pay $100,000 compared to paying a radiologist might be quite strong. So I think have to think about that as a concept, because in Australia, interestingly, the barrier to spending this money to use AI, even though I'm showing you the benefits now, is actually quite high, and there's a few reasons for that. So just switching gears now, this is work that we're doing with Kamlesh and Xiaolin Chen and Gary Egan at Monash Biomedical Imaging, and we acquired the MRI data from our scanners here at the Alfred, and we send them to them to train a CNN model to remove either motion degradation or to improve signal to noise in MRI images. And with this, we can actually improve the image quality using deep learning reconstruction. So we're doing this now for a few different clinical applications in MRI. But these are products now that people are using in CT scan and MRI scans to be able to acquire images very quickly, but with low radiation, and then doing deep learning reconstruction to improve the image quality. Here's this is a portable MRI scanner, and we have one of these at the Alfred now, and these are ultra low field. So, when you think that normal MRI scanners are 1.5 to 3 Tesla, this is a 0.64 Tesla or 64 millitesla scan. So it's extremely low field and relatively inexpensive. And we have one of these at the ICU. We can actually wheel the scanner bedside next to the patient's brain, scan the brain, and then acquire the images. You can see that the MRI images have less signal to noise, and the image quality is not as good as a 3T scanner. So you could argue that has some point of care utility, but the image quality is still not very good. So one of the projects that we're doing is using deep learning recon to see if we can improve the signal to noise and improve the image quality for these scans. Another project that uses NLP is a project with Monash Partners and King's College, and this is quite an interesting project where we're actually using CogStack, which is a tool that King's College have been developing in concert with Monash Partners to look at both structured EMR data as well as unstructured data. So, for example, PDFs and so on that resides within EMR, to try and look for patients for clinical trials and to do cohort identification for research purposes and potentially for clinical registries and so on. So an example, and this is work that we've been doing with Helena, Monash Partners, and Joanna, Adam Morris has been, as well as our digital health team here at the Alfred. And we've actually developed the first model now with our radiology team to detect patients in our EMR to recruit them for clinical trials in one of our radiology clinical trials. It can also be used for cohort discovery. So if you have, say, a research project and looking for patients with lung cancer, we can use this model that utilizes NLP and MedCat to identify patients for cohort discovery. And another potential application of this, so for example, if you have a fracture or whatever, or if you have a particular heart abnormality, we want to try and predict with the information that's already within the EMR what the outcome is for this patient. So in other words, if it's the same fracture as some of the other patients there, we know some of these patients will have complications and the fracture may not heal. Other patients with a different fracture may actually heal very well. So we can predict outcome in patients with using this technology. And then just briefly now, I think the advancement of a lot of these medical imaging tools has really been accelerated by some of these Kaggle challenges. So the RSNA, which is a Radiological Society from North America have been holding 4 or 5 Kaggle challenges now every year. One of the recent ones was, again, because of the difficulty in detecting pulmonary embolism and clots in the lung, they had a Kaggle challenge where you can see that quite a number of teams, 305 teams, submitted solutions for this. And in this way, we can accelerate how we develop models to the clinical setting to solve a particular problem. In the last year, we had identified that patients that have lines and tubes getting put into chests, particularly patients that have COVID, we wanted to detect whether these lines and tubes were optimally placed. So we actually hosted a Kaggle challenge with the Australian College of Radiologists, and we had quite a number of, again, probably about 300 teams that were involved in this Kaggle challenge. And we published the definitions led by Jennifer and Jarrell for these lines and tubes that we hope can be used. And this is, there was a lot of work with a lot of these radiologists that helped to label 30,000 chest x-rays from the NIH chest x-ray 14 data set. So the labeling took a lot of time, but then we were able to define a data set that can be used for developing these models. Lastly, I think the last 5 minutes or so, I just want to leave some time for questions. I think I have a few slides in this, but I think we're all using these tools now in our clinic, but we need to tell our patients that we're using this, no? And not only that, but we need to potentially be able to explain, in explainable AI, how these models actually work, so we can explain to the patients, number one, how it works, and then also understand what potential consequences are if the AI model makes a mistake. So we won't understand how it makes a mistake unless we understand how these models work. And these are, I think, quite important concepts for us to understand. So a lot has been written about this now, and some of the ethical concepts. So we need to tell our patients, have you been told that, and all that list of the 6 different categories of AI that's being used, we're doing all of those things, but I don't think we're telling our patients that we're using all these tools in medical imaging. So for example, if a urologist uses AI to decide on how to treat a patient with prostate cancer, and then he decides that I don't really like what the AI is telling me, I'm going to do surgery anyway, because he has to pay for his Porsche or some other sports car that he's buying for his wife or his husband. You should probably know that he's overridden the AI treatment plan. And I think you should be informed of that. So there's lots being written about this now. And this is, if you look at the ethics literature and AI ethics literature, I think questions of who must be told, the outside role of AI in clinical decision making, the fact that if you're using AI to reduce costs in a patient's care, we probably should tell them that, right? And we're using AI to reduce the, instead of paying for 20 radiologists, I'm using AI, I'm only paying for 10 radiologists. I think we should probably disclose that to our patients. So Warren Clements is one of our radiologists who is very interested in this, and he did this prospective study in asking patients who come to our waiting room about what they think about AI, whether they know that we're using AI. So we gave out some surveys. 283 patients were surveyed to ask questions about whether they were comfortable in us using AI, whether they knew we were using AI, what the medical risk is, and who is liable when AI makes a mistake in the clinic. So it turns out 63% of the patients, so almost 200 patients, were completely unaware that we're already using AI in the clinic in the patient care. And in terms of how comfortable they were, 4 out of 7, if you use a 7 Likert scale, that was the level of comfort. So not uncomfortable, but not completely comfortable. 7 was the most comfortable you were in using AI for the care. And if we were using AI, they felt that the accuracy or the AUC, the error on the curve, should be at least 90%. Because I think as humans, typically the AUC is roughly around 90%. So if you're making mistakes, who's liable? the company, the hospital that's using the AI is probably liable. I won't spend a lot of time, but a lot of this is being written in the literature. The problem of medical errors in AI, who is responsible for this if a AI makes a mistake. Physicians should be responsible ultimately. Healthcare teams and the hospitals should be probably responsible for this. And when we asked the patients that came to us, they felt that perhaps the hospital, 76% felt the hospital is liable for a mistake that AI makes. 61% thought that the AI company is liable, 37% with the radiologist, and 10% with the referring doctor that referred them to radiology. So interesting. The second part of a second paper now is being written by Warren, and he's got the results of this. And instead of asking the patient, we're actually asking the hospital clinicians who are referring patients to us similar questions in terms of data privacy, in terms of using the data, AI companies using data for second use. And this really is, I think, an important question. If we're sending out data to the cloud for an AI company to use their model, does the AI company have access to the data to either improve the model or developing other models? And so the second use for data is another important concept. So I won't spend too much more time talking about this, but again, in this survey here of 12,000 patients, should AI be used in your surgery? So in other words, if you're a surgeon and you have a robot that can help you do the surgery, 47% of patients were okay with it, 36% for major surgery. So perhaps they're not particularly comfortable, but we should probably tell them that we're using a robot to augment a surgeon for their surgery. So I think that the final item that I want to kind of raise is who actually owns the data and should we have consent? And this is work that some of our colleagues at Monash University has been doing. So if you to use medical data for developing models, we should really get consent. And this blockchain consent, similar to Bitcoin and so on, blockchain currency. There should be a method for us to each time in a blockchain fashion ask for consent and the patient's agreement for us to use their data. And it comes back to the fact that how do we do this properly and who owns the data? If you are providing your data for medical care, I think everyone is happy that this happens and we don't have a problem with using our own data for medical care. If you're using our medical care data for research purposes, I think most patients are also happy with that. The minute that you're using medical care to develop a model that can be used for commercial purposes, I think that raises a whole bunch of different issues in terms of monetizing our own data. And so people are talking about now who owns your own medical data. Is it owned by the patient? Is it owned by the hospital? If the data is being used to develop a model, and then that model is creating a commercial product, should you be able to get a share of that model and share the company? These are all questions that I think are important, and if that's the case, then maybe we should be selling our data. Maybe there should be data brokers that could be monetizing our data. Important concepts and questions here about use of AI in a public hospital and a clinic. So hopefully I've shared with you some of our challenges in adopting AI in the public hospital setting, why it's good to use it, why we should tell our patients we're using it, and what future some of these startups might have moving forward. So some important questions. I think if I had a crystal ball, then I would invest money in some areas and maybe not others, but I don't really have a crystal ball. But my feeling is that, and I've shared with you my thoughts on what happened with some of these companies. And this is kind of backed up by our current environment in the medical setting, and also what's really happening out there in the commercial environment for AI. So thank you all for listening in, and happy to take any questions. I'll hand back to Jackie and to Zhongyuan.
Thanks, Meng. That was a really good talk. We definitely have some questions come through, so we'll go through those ones. I'll start with the first one that came through. This went back to one of your, this came through probably halfway. Can you see the question and answers there, Meng? Yep.
Yeah.
Yes, the first one was about that false positive rate might mean there might be additional unnecessary tests or treatments, and if that's a concern.
Yeah, so that is a concern. I think the good thing is that these models always still need to be verified by a human person. So, so if an AI now is detecting a hemorrhage in the brain, no one would do any additional imaging or act on it or institute any medical therapy without a human person actually verifying it. So, so I think the concern is that, and that's why there's a need for a human person to actually look at this properly and a human radiologist to look at it. So the problem is if it gets into the wrong hands and it goes to a clinician that's not a specialist looking at these images, then they could potentially make a wrong decision or cause other tests to be done without a human radiologist providing the final expert opinion.
Yeah. It's good that there's still someone at the end there as well. But now the other one that a person asked as well was why did the turnaround time decrease in the emergency department but increase in inpatients?
Yeah, that's a good question. So I think our priority in any public hospital is to ensure that the ED work gets done because that's the most acuity in terms of patient care. So our focus for staffing is to get the ED reports done. So if there's an abnormality with the ED report, we'll do that one first, which means that sometimes we would spend and devote less resources and staffing to the inpatients, which unfortunately might mean that it might take longer for us to get to reporting an inpatient report, and that might explain the increase in turnaround time for our inpatients.
And the next one was from the industry perspective, Australia is lagging behind a bit, but is willing to see some success like Harrison AI, $100 million plus raise. How friendly do you think the Australian healthcare system welcomes medical AI SMEs so far? Yeah, so that's a very good question, and the adoption of AI in Australia far lags behind the US and also in Europe, and I think I probably didn't. I tried to explain why that's happening. I think in Australia the medical legal environment is more friendly in Australia, so people are less likely to need to think of using AI to help with the diagnosis. And so I think the healthcare system in Australia is not as friendly in adopting a lot of these AI tools, partly because of that. And it's interesting that for those of you who are familiar with Harrison and with Annalise, they've partnered with Radiology, which is arguably the largest radiology private practice in Australia. So they're rolling out their tools in the private practice, which I think there is a role for AI in private practice because there is much larger volume of imaging that happens in private practice, and so probably less time for a human radiologist to look at these images. So I think in private healthcare system, I think there is a role for it, and I think there's probably going to be far more adoption of AI. In the public hospitals, I think for the reasons that I explained, and also because there is perhaps a bit more focus on human discussion and human reporting of abnormalities, I think the adoption is going to be low. And partly also, I think the business cases and justification for spending money on AI is going to be lagging in America and other countries. And then someone else has also followed up to that question. Is TGA FDA essential to enter the hospital? So getting 100+ diseases certified certainly takes a lot of effort, yes. SMEs may not be able to afford it. Yeah, so this is an important question too. So certainly a few of these tools that we were reasonably early adopters at the time did not have TGA or FDA approval, and we got around that by you can either get authorized prescriber usage if so, but the way that a lot of these companies get around this is that these are not marketed as true AI detection tools. So I think and Zhongyan might be able to correct me if I'm wrong, but really the only truly diagnostic tools are out there are these ones that actually
look for diabetic retinopathy and actually make a diagnosis. A lot of these medical imaging tools are not making a diagnosis, but really quality assurance QA tools. So they market it as such rather than actually making a diagnosis. So you don't really need TGA approval, although that environment is changing now. And so if you don't have TGA approval, the other way we got around it was to do it as a research project. So we required ethics approval and a clinical innovations committee approval. And we were able to use it and do it as a research project rather than as a clinical tool.
Yeah. I think we might run out of time for some of the questions. I might ask one more. I like this. When do you think that AI in radiology will mainstream practice in Australia, if ever?
Wow, that's a really good question. Well, you know, there are a lot of, well, as I said, in private practice, I think it's already being adopted quite widely. And I think in the public hospitals, it seems to be, you know, there are not many public hospitals that, interestingly, around Australia that are adopting it. I think, I don't know the answer to that question, to be honest. I think that as it is, it's probably going to be a while. I think that as the larger companies, so for example, the Siemens and the GE and the Canon and so on, you know, in many cases, some of the deep learning recons is already mainstream and being adopted. I think some of the diagnostic tools that are being used, as they become more incorporated into these HIE and these VNA PACS platforms, and really they're being called AI platforms now that are in these hospitals. As it becomes incorporated into these platforms, I think it will become more mainstream. So I don't know, maybe 3 or 5 years time might be a good timeline.
Yeah. Can I ask one more? Because I think this is a good question, but I think that might be our last one. How practical do you think it is to obtain patient consent for use of AI in their management? So for example, an ED patient getting imaging, which I think is important because you might not be able to ask someone, but it's still going to help their care. So that's a good question.
Yeah, I think that's I think from one of my colleagues, Dr. Liu. Thanks, Phil, for that question. It's not very practical at all for us to tell patients each time we're using AI. But I think as a patient, we want to know, but you know, currently we don't do it. So in the day-to-day care, it's probably not something that we can do very easily. The last question that Monica raised is very and that was exactly the point I wanted to make. I think that if you were wanting to save your own data for commercial purposes, then everybody should really, you know, perhaps get a share of a company that's developed a product using your own data, right? It's very difficult to I guess police this, but you know, companies like Google and Facebook and whatever, they're constantly using our data in the algorithms and models. We don't have a share of these companies, but I think that in the setting of medical healthcare, if a company is using your data to develop a model, I think that you should be, you know, perhaps open to a share of that company. It brings up some very important concepts and I think ethical issues of, you know, what companies should have access to, because the principle with this is that data and medical data is expensive, and you know, medical data is hard to come by, particularly when you're developing models to create these commercial products.
Yeah. Well, that was a very good talk. I think that's really put together everyone's role as well, like the patient's role, the human, such as the doctor's role, as well as the AI, and how it all can come together, which is exactly what all these seminars are trying to aim to do, is bring all those industries and professions together, and how we can all work together to get the best outcome for the patients and the healthcare. So that was really interesting, and you did raise definitely some challenges and some things that how it can really help, and also some considerations. That's really been very interesting. So thank you so much for your talk, and thank you everyone for tuning in today. And I just want to say as well that these talks have been supported by the Just give me 1 second there. I was going to say at the start that the talks have been supported by the Medical Research Future Fund, and that's why every 1 to 2 months we will have another talk on AI and healthcare to keep everyone connected there.
Right, brilliant. Okay, then due to the interest of time, so we will announce the close of the session. Thanks, Meng. Thanks, Jack. See you next time.
Thank
Thanks,
you,
everyone.
everyone.
Thanks for having me. Bye.
Bye.
You're stopping the recording now, Jackie? Yes.
I'm sure I want to stop recording.